My name is Jason. I am a SPEc patient or student doctor, standardized patient for the testing center. I've been doing this since March of 2011. In addition to that, I'm also an HIV educator, a cardiac nurse, and I do community work, psych work. So I've done a lot in the health-related fields. As a nurse, I know one of the most nerve-wracking things is to enter that patient's room for the first time and not know exactly what to expect from this person. And somehow I think most of you can relate to that now that you're entering into the field of the DO program. By the way, congratulations. I have seen DOs in action and I've seen MDs in action, and I really think you guys bring an extra level of humanity to medicine, which is sorely needed. As for what you guys are doing with the SPEx, as you call them, you have, I know, rubrics. You have a biomedical rubric, and then you have the patient rubric. I don't really deal with the biomedical stuff anymore. We deal with just how you interact with patients, the human aspect of it. Basically, I believe what part of your program is trying to teach you, and what reality is reimbursements and business really factor into healthcare. The better you treat your patients, the better scores you get on HCAHPS scores, the more money you get for reimbursement for Medicare, Medicaid. Also, if you're in the private practice, which a lot of you might eventually go into, your first interaction with a client at a community center, or if they were referred to your business, is going to make a lasting impression. If they feel that you're warm and intuitive and interested in them, that often can overlay the fact is that you might be a new DO starting out on your own. So one thing I would love for you all to take away from this is always give yourself credit for when you've really made the personal connection with somebody. Most people tend to remember that over the critical skills. I'm not saying don't do the critical skills. I'm just saying is a layperson's going to remember that doctor that genuinely made eye contact, sat at eye level, listened carefully, spoke in a calm, easy tone of voice, and then summarized what you said. Summarization is key to showing your listening skills. It's also key to your rubric. I know what you guys want to know about. I graduated from nursing school, believe me. So what I would like to suggest everyone here do as a way to start any encounter, because these encounters are going to start very long. Your first year, you're going to do like a family history encounter, then you're going to do like a minor problem encounter. Those could be 25 minutes, and they're going to start going to 20, 12, smaller and smaller as you go along in the program. So what you want to do is really use your time to your advantage. One thing I would strongly suggest is, unless you're absolutely sure you have covered every single basis in it, don't leave the room before the announcement's over that you need to leave. Unless you're absolutely 100% sure you want to invest that time in your SOAP note out there. If for those encounters you're not even writing a SOAP note immediately, try to stay in the room. And if you think you've done everything, there's nothing wrong with saying, I'd like to review my notes in here to make sure I've covered everything so I can make sure I gave you the best possible care. No patient is going to say, get out of my room right now, for doing it, because you could be surprised what you might have missed that could be really pertinent later on. I think to start with, why don't we start with how I think is an effective way to start the encounter. As all of you who have had SPEx before know, you're going to be brought into the hall, the standardized patient hall. You guys line up in front of a door. There's a door sheet in front of there. And then I think when they say you can begin the encounter is when you get to look at the door sheet. So what you want to do is be organized beforehand. Have your yellow pad out. If you have mnemonics, like I know you guys do the PQRS-TV or something like that, have all that out there. Have like patient's name written on the top, date of birth, chief complaint. You know, have those things ready to go. Have that. You might even want to write on there, summarize at the end of it. So you've got all that organized before the encounter begins. Then when they say you can begin the encounter, take a deep breath. Believe it or not, it calms you down. Remember to smile, reach for the sheet, understand what's going on, write vitals if they're appropriate, write the person's name down, and then when you're ready, there's nothing wrong with taking 30 seconds to a minute to organize your thoughts before you go in there. If you have to do that, each person's different. Each person has their own set way of doing things. But the best thing you can do is set up a strong first impression. Once you feel you're ready, knock on the door. The person will say, come in. They definitely will say, come in each time. And then you smile. And for the next 15 minutes, that person is the most important person in your life. And you just pretend that for the next 15 minutes. Good morning. How are you doing this morning? Sanitize your hands by the sanitizer in there. It's always going to be by the door. I always find personally as an SP that it's a little bit more effective to have the doctor greet me and sanitize there than to say, hi, I'm the student doctor. Hi, how you doing? Oh, good weather out, by the sink. It's a little bit more effective, I think, to actually interact with the person and get the eye contact going. You verify, oh, hi, and you are Mr. John Smith, is it? Oh, hi, how do you like to be called? How do you like to be called? John. Nice to meet you, John. Just sanitizing my hands. Good to meet you. How are you doing today? Great. Are you comfortable right now? I am. Great. You've established rapport. You've established their name. Might be a good idea to also, can I just verify date of birth? We have standardized dates of birth. In real life, you're going to want to make sure you've got full name and date of birth. For here, that's the icing on the cake. You've not only established and greeted the person, you've established their identity. Because what happens if there's two John Smiths in the clinic and you're going to the wrong room and they mixed up the door sheets? So we've established rapport, and then we say, are you comfortable? You've established comfort level. Is there anything we can do? You've sanitized your hands. The next thing I think is very effective for a doctor to say is, would you mind if I sat down and take some notes so we can make sure we get you set up with the care you need, or something along the lines of that. You're asking permission, you're giving the patient the empowerment. So, of course, they're all going to say, sure. You sit down, eye level. You say, okay, so what brings you in today? If you set up each encounter like that, you've established rapport, you've established eye contact, you've set up a personal connection with this person. And most SPs are going to say, wow, this person really is into me, really cares about what's going on. And you could be as nervous as heck on the inside. I mean, the point is that you're making the effort and you're coming across as confident. Because sometimes in medicine, we have to fake it a bit. You're not sure what to do, so you listen and you reiterate. So they'll tell you their chief complaint. You'll acknowledge it by saying, oh, that must be challenging or difficult, or, well, let's see if we can help you out with that. Okay, so now they feel like they've got a communication going on with you. Then they'll give you, and then the brave, brave, brave student doctor will then say, could you tell me how this, or when this began, or can you tell me how this developed? Most people are terrified to waste their 15 minutes like that. But the reality is you're going to get a lot of very good information if you're willing to take that route with somebody. You ask them the questions, you acknowledge what's going on. And then, guys, if you don't take anything else away from here, the next point's key. Summarize what they said when they're done. May I just repeat what you said to make sure I got it all this information correct? And then if there's any mistakes, the SP will correct you. Because sometimes what we think we hear is not what the person said. And that could be really important, I think, later on if, for whatever reason, your guys are getting to the point of differentials or diagnoses and you don't know, you might have missed something rather critical. So, any questions on that so far? Any thoughts on that so far that anyone wants to share? Okay. For those of you that have had SP encounters, oh yes, I'm sorry.
For my SPEx that I had on Monday, first year, I actually completely forgot to wash my hands right when I went into the room. So I made a mental note to wash my hands before I actually touched them. Do you think it makes a difference whether or not you wash your hands like immediately or like right before you make contact?
Excellent point. What I would suggest you do is use a hand sanitizer first to shake hands. Then after you've talked with them for a few minutes and established contact, to say, now I'm going to start the physical examination, but I'd like to wash my hands in the sink. So that way it's less awkward and you're communicating what's going on. But to sanitize your hands to shake a hand is usually considered acceptable practice everywhere. If you want to get more in depth, because I know you guys don't use gloves, washing your hands at the sink at that point, the person's going to feel a lot less awkward than to have your back to them for 15 to 30 seconds while you're washing your hands. And the rooms are small, and they're not designed to wash your hands right by the door either. You usually have to run past the patient to do that. Any other thoughts? No? For those of you that have had SPEx before, what were some of your first year fears that you were thinking of, or things that you discovered as you did them? Andrew?
Someone had pathology and said, oh yeah, I got shoulder pain. I'm like, oh, that's great.
Yeah, often you want to, it's great to acknowledge it, but you want to be careful what terminology you do. But yeah, that's a valid point that a lot of us sometimes don't realize what we're saying because we're thinking about something else. Yep.
I had my SPEx on Monday of first year.
Congratulations.
And thanks. I found that I had to remind myself to actively listen to what they're saying because I was also thinking, okay, what comes next? L, O, Q. Like I had to try to remember my list, but also listen to what they were saying at the same time, and I found that kind of difficult. But I guess that just comes with practice.
It will come with practice, definitely. Did you pre-write up the alphabet on your sheet? Might be something to think about. The other thing is, I encourage you guys to practice SPEx on each other. There's nothing to say you guys can't go into a random room and just practice knocking on the door and all the motions just to get comfortable introducing yourself and introducing what your level is. Full name and level is something that they really want us to know that you guys are communicating. It's not like, oh, hi, I'm Jason. I'm a student. Okay. Yep.
So something that you kind of had mentioned, and I think I struggled this last year, was we're trained to have this OPQRST mnemonic and check off things and ask questions in an orderly fashion. But when you walk in the room and say, hi, so tell me about what's going on, you're already not in that checklist. You've already thrown that out, and now you're just kind of running free. And I think that's where writing down the OPQRST, so as Jason is telling you that information, you jot it down where it was, and you still remember to track what you're listening for, but you also...
Exactly.
And that's a tough balance, and that still gets me. Like when that got me at my first SPEx this year, where I totally got off tempo just on that first 30 seconds, and I got a ton of great information, but then at the end I'm like, wait, what didn't I get?
Did you ask for a summarization, or did you summarize?
I did. I mean, I figured it out before it was over. But I was thinking about figuring it out while the patient was still talking. And now I'm not listening to the patient because I'm trying to figure out what I had missed.
And that is something else that will come with time, but it also is the balancing act of real-life healthcare. If you're working in the emergency room as a DO, I got news for you. You're not going to be able to go for you're going to have to prioritize and then backtrack. It is part of it, but that's part of what this is trying to do, is to give you that first foundation so you remember what are the priority skill sets.
I completely agree with jotting down stuff before you go into your room. Even with your CSAs, when you have to do review of systems and you have these questions you have to ask, your facilitator will just ramble at you. And if you just take the time to stand at the door and write out all your acronyms and then check things off as you go, you won't have that fumbling mess even during your test. So it's useful for SPEx and it's useful for your CSAs. That's something that took me a while to learn.
And not just checking off things as you go, but writing a key word from whatever they said that will jog your memory. So when you summarize afterwards, you're not just saying, oh, I asked you about the pain in your shoulder, but you actually can say, oh, you said the pain in your shoulder was sharp. And next year, that becomes important when you leave the room and you actually need to write down all the questions you ask and the answers. And if you didn't take notes, then you're trying to remember, did I ask him about radiation? And what did he say? So I think taking that time, like you said, to get organized before you walk in the door.
Yeah.
Like sometimes when I try writing down stuff where the patient says, I lose eye contact. I try to write down as well as make eye contact, but then I don't have that ability. I have to look down and make sure they come back up. How do I fix that?
So I'm going to be your student doctor today, I wish. But is it okay before we begin that I just take some notes as we go along to make sure I'm getting the right information to give you the best care I can? So you've acknowledged it. I mean, I think that more patients would rather have a doctor that says, I hear what you're saying and I want to make sure I write it down, than to say they're faking it. Oh yeah, sure, okay, yeah. Yeah, great, awesome. Okay, bye. All right. Sorry, was somebody else? Yeah.
I always run out of time, especially this year. I'm a second year, so we have 24 minutes to do chief complaint, past medical history, review of systems, physical exam, all in 24 minutes. And I think first year we had I don't know, just half an hour, 40 minutes just to do past medical history and vitals. And now we do everything in 24 minutes, and then we come up with a differential diagnosis at the end. So I just feel always rushed for time.
Well, as we said before, that we learned. Have you done the alphabet on the paper, the legal pad at the beginning, and all your little notes to set up the?
I don't forget things to say. I think I just I get distracted really easily or something, because my patient had low back pain, and then he was like, oh, excuse me, sorry, I couldn't hear you, and I was like, oh, what's wrong with your hearing? Are you wearing hearing aids? And I just got really distracted.
Okay. Well, the other thing that can be helpful is, like I said before, practicing with each other. Create your own little problems, and then have the person, then you have to kind of guess it. So, I would definitely try something like that. And, the more and the other thing is sometimes the office offers, sometimes they have extra spots available. It doesn't hurt to ask your professors, is there any times to do extra practice encounters? Yeah. Anybody else? Yeah.
So we get some of the best information from asking open-ended questions, but occasionally the standardized patients, I'm sure you guys have a lot of information to memorize too, will give you a massive list. So if you ask is there anything significant in your family history? And they go on and on and on. So is there from a patient perspective, what's the proper way, or how would you like to be sort of steered back to what's pertinent?
Okay, if you're asking about my family history, for example.
Well, in general, so say you're going on about you're mowing your lawn and the dog ran in front of your car, and you're going off on a huge story. It's basically erroneous information. How do you steer your patient sort of back to the where they should be, that track of answering medically pertinent questions?
I hear what you're saying. What I would say is, generally speaking, at least for these encounters, we're not going to create a long-winded backstory for you guys. In real life, they might. But what you would say is, if I'm here with back pain, and you said something like, oh, can you tell me about what happened? I said, well, I was mowing the lawn, and then the dog ran in front of me, and then I did this. I might say, oh, okay, and did that cause the back pain? Bring it back to what the issue is they're involved with, as opposed to, if they start saying, then my wife was clipping coupons and she went to straws. I'm like, oh, okay, what I would like to do is why don't we get back to your, acknowledge what they're saying, but try to get back to it. I don't think most SPs are going to try to go off on that kind of tangent with you. But at the same time, guys, and this is key, please don't say something like, oh yeah, just tell me about your family. What? You kind of have to ask a detailed question like, is there any chronic illnesses with your mother? Or I'd like to talk about your family next. For your mother, does she have any chronic illnesses or any health conditions I need to know about? That's clear, and we'll give you that information, but we wouldn't, you can't just ask a generic question. You got to be very clear about what you're looking for, because often we'll be like, I don't know, because a lot regular patients are not going to have a detailed list of everything going on in their lives if you don't ask them the right questions. Anybody else?
What about the hard questions, like monogamous, sexual activity, illicit drugs?
I was going to go into that next. Yes. Okay. When you guys are doing health histories, it's always fun when you start to say, you find out, it's like, oh, how are you? How you doing? All that stuff. Preface this. We're in New England. We're repressed up here. So you want to preface that stuff. Say, these next group of questions are going to give me a better understanding of your overall health history. Some of them might be very sensitive. The more open you are with me, the better understanding I have of the whole health history. And then start with something a little bit more like, oh, do you drink alcohol? Yes. How many drinks a day? Okay. Okay. Do you smoke or use tobacco? Do you smoke? Yes. Do you use tobacco products? No. Okay. And any illicit drugs? Do you take any illicit drugs? You know, and then you can always say is like, just so I know better for your whole health history. These next questions are going to be about your social life or your social situation. Do you have, are you sexually active? And then you start to go into it deeper. Okay, what kind of sexual activity, or you know, are you using condoms, or you know, have you been screened for an STD, or would you like information on that? You know, so you, instead of just saying, you know, are you drugged? Are you using drugs? You know, okay. All right. How many sex partners did you have last night? You know, it's you know, it's all about developing that rapport. And again, if you set up the original like interaction with them, people start to let down their guard. And the more they let down their guard, the more free and honest the information will be. Because the last thing you want to do is appear judgmental. You want to be there to help them. Okay. What I'd like to do now, since we've covered that part of it, is just, because I know some of you guys need to leave soon, is talk a little bit about effective closings. And I think this will benefit the second years as well as the first years, because I think some of you guys haven't gotten a lot of tips on that. Okay, so you've done a spectacular entry. You've developed a warm rapport with somebody. You've done your full intake. You summarized. You did your physical exam. Oh, key with physical exam is let them know if you're going to be doing like a back exam, face them first and say, for this next part, I'm going to go behind you and touch your back, if that's okay. Instead of just running behind them and then start, what do you feel? People get a little, you know, personal space. They want to hear what's going on. So always communicate what you'd like to do, not what I am going to do. What I would like to do next is to listen to all the areas of your lungs for your lung sounds. This is going to involve lowering your gown a bit or whatever. And we have a drape available if you'd like it. Always offer the drape. Never hurts. It should be there, but if you don't see it, say, I'd like to offer you a drape now, because modesty and dignity is one of the things that we look for. So again, one of those things to throw into every encounter, even if you're looking at their feet. You know, would you like a drape for your legs? You know, it just shows that you're making the extra effort. But going into closing, so what you say is you've talked in the beginning, you've got their information. ICE, you've gone over their ICE in the beginning, their concerns, their expectations, and their ideas of what's going on. That's part of your initial intake. At the end, to say, earlier your idea of this was that you sprained your ankle. What I'm seeing is consistent with that, or it might not be consistent with that. Your concern was the pain. Here are my suggestions on how to deal with the pain, you know, rest, elevation, ibuprofen, whatever. And earlier your expectation was you wanted to be able to get back on your feet as soon as possible. I think we can do that with this, this, and this. So you would readdress the ICE again, and then you always say, how does that sound to you, Andrew? I'm picking on Andrew because he's the only name I can remember. How does that sound to you, Andrew? How does that plan of care sound?
I think it sounds good.
Good. Because what you want to do, oh, is there anything, good. Oh, is there anything else, any thoughts or anything else, concerns that we're not addressing that I need to know about?
I think you got it all.
Okay. Now that's key, guys, because at some point, you might have this super plan of care, like this person's suffering alcoholism and needs to go into detox immediately, and you go, I want you to go to detox today. How do you feel? No. Well, great, because detox is so important and you're going to love it. And no, you know, you got to make sure the person is going to be invested in it. If they don't want what you want, you're wasting your time trying to educate on them. You got to find out what they're willing to work with you on. That's why it's always key to say, this is what I would like to offer. This is what I would like to do. You're making an agreement with them. It's no longer just doctor's orders. It's a partnership in developing a relationship with them. So that's like a key point to remember, which brings up another point. So you do that. Then you explain, you know, you can explain your options of what's going on. Like say it's an x-ray or a blood test or something like that, and the person might be somebody who's uninsured and has low money, very little money. So if you ask them that and they say, you know what, it's like, I really don't have a lot of money. Is there, you know, any other option available? You know, you can then say, well, you know what, we might be able to offer this or this. And that's the advantage I think you guys have in the second years, and check with your professors, but when you're closing, you can set up your own little story. Like, you know what? There's a free clinic down the street. What if I called them up and set you up there this afternoon? And then I'll get the results back, and then I'm going to call you tomorrow, Andrew, and let you know what the results are so we can make the next step. How does that sound to you? You know? Throw that in there because you guys have the flexibility to do that. Clarify what the next step you'd like to do. If they're agreeing to it, clarify that you're going to carry them to that next, they're going to schlep them on your back to the next step. So you don't just say, okay, great, I'll see you later. You know, make sure they know where they're going with this. Because if they don't agree with it, or if they're confused, and they're either low educated, or they're scared, or they're, you know, they haven't had all their concerns addressed, they're going to get dressed, run out the door, and never come back. Yep.
I think going on that same point, some of the best success I've had with closing is like completely taking a narrative out of nowhere. The other day I arranged for a visiting nurse for somebody's husband who had a needle.
But that's a great thing.
Any of that stuff.
Guys, you're acting in this.
Yeah. She was thrilled. She was like, you cared about my husband, you cared about me, you wanted to make sure I wasn't going to be hurt at home. And like, I just totally made it up. So I think having some creative, I don't know, just feel empowered. You're the doctor, you're playing the doctor.
You are the doctor. And in a couple of years, what you're saying, you can actually write orders for. Get used to it. Now you have the authority to actually make this difference. So if you think about it. Think about what and also think least invasive versus most invasive. If they're having chest pain, well, we do your vital signs. Maybe we're going to draw some labs and do an EKG. You're not going to, I'm rushing you in for open heart surgery tomorrow. But that's the way you can do it. Is you talk about here are the standard, and I'm assuming you guys go over this in classes, what the protocols usually are for what the least invasive and most invasive. So what I'd like to do next is run some tests, some diagnostic tests, X-rays, labs, whatever. But yeah, that's the key. It's like if you got that, and then you let them know what's going on, and they're in agreement with it. You guys really have developed a partnership to make this person's health better. Any thoughts? Anybody else? Andrew, what other challenges do you see going into your second year?
Forgetting things. We were at Soap No, and then I went in, didn't get his age or his name, so I wrote it up. It was just a Caucasian male. So, Asian name.
Is that something you're going to remember to do next time?
Oh, no.
Yeah, okay. Learn from your mistakes, guys. Watch your videos. I think you guys have them available to you. Look at them. See what's going on. And then, critique them. And then look at the checklist that you got scored on and say, oh, yeah, maybe I could have done that better. Or maybe I could have done this or whatever. But it really can make a difference to, because these encounters actually are, the more of them you do, the better you get at them, like with everything else in life. The more you do public speaking, the more comfortable you get with it. And it just is part of it. And part of it is portraying that confidence that you are medical professionals. And in a couple of years, this will be reality, and you guys are going to have the skill sets to do them. You get through medical school, you can do this. It's just making it as therapeutic and as effective as possible. It's going to just take the time to know how to set up the right steps. Any other thoughts anyone has?
You mentioned the confidence.
Yep.
And I think that's interesting because I've heard people get different feedback based on either portraying too much confidence, kind of being too
arrogant,
versus people who are too casual. And I know it partially depends on the standardized patient, but just like in the real world, it also depends on the patient. Do you have any recommendations for how to judge? You walk into the room and you have to kind of figure out what role you're going to play based on who's in front of you.
Well, part of it is as you're going around into it, you're going to have, that's an excellent question. That's going to be part of your emotional intelligence of reading people. I would suggest, like how I described setting up the encounter, is you're being professional, but you're also meeting them at their level and being very respectful. You're getting use their preferred name in the encounter. As I said before, get their preferred name and say, well, John, it's nice to meet you. So John, tell me a little bit more about this. So John, what I would like to do next is check your back over for any bruises. Is that okay with you? That's being professional and assertive, but you're not being arrogant. Body language is another key point. I mean, you want to be able to go in there, you know, lean in, look at them, you know, take your notes, lean forward, eye contact, and then I'm just going to write some notes down just so I can make sure I got everything. Versus, yeah, tell me more. You know, you'd be surprised. Some people, if they're nervous, they actually get into like giggle mode, or they just sort of like kind of do this. I've had some people actually like kind of like, what are we supposed to do next? You know, or like, come on, what's the real story here? You know, don't do that. I'm serious though. You can have everything from somebody who's very nervous and wants to do a good job to somebody. I actually had a doctor who had already passed his boards but had to do his last SP with us. And the guy's like banging on the door saying, come on, I got lives to save in here. And walks in and he goes, oh, I'm so sorry for all your pain and suffering. You know, you'd be surprised how the difference in people's attitudes are. Attitude makes a big difference. But if you're going in there with the eagerness to help, most people are going to want, because they're there because they want to be helped. Now, it's possible you might get a SP case or a real life case where the person is not going to go for whatever treatment option you have. You can only recommend your treatment options. But I would say most of them will be, as long as you're communicating what you want to do beforehand and you're getting permission, most people are going to be very receptive towards it. And the reality is if you're working in an environment such as New England where a lot of older patients are here, communicating like that, talking to them, asking their opinion and their thoughts, some of these people are very lonely. To actually have somebody that shows that extra initiative is not going to come across as cocky. It's going to show as they're very therapeutic. You know, something to think about, you know. Anything else? Yes?
So what would you say is the best way for us to correct when we messed up? So for vitals, so a lot of us, it's the first time we're doing vitals, and we're doing it, and we're just like, we can't get it.
The blood pressure cuff is blowing up and flying across the room, yes.
Like, we can't find their pulse, or we like messed up counting 30 seconds. What do you suggest? Like, do you suggest we acknowledge it, be like, oh, I'm sorry, I made a mistake, I need to do this again, or?
You could always say this, you know what, I'm not entirely sure I got an accurate one. Let me try it again on the other arm.
Okay.
I'm a nurse, I deal with it all. I mean, I've had exploding blood pressure cuffs go all over the place. I've had, you know, I'm a visiting nurse and they want us to use manuals all the time. So I know how to do a manual, but a lot of people want the automatic. And sometimes if they're large, those cuffs don't always work well on them. So you have to do the best you can, but you acknowledge it and move forward. Yeah, and that brings up another point. I think you guys have all been taught this, is don't tell them you're about to look at their respirations, you know. Do, 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 do. You know, because then they'll stop breathing because they're afraid. But yeah, just again, communicating that. And I think, and again, in real life, somebody who's honest and acknowledges and isn't faking it is so much more gonna get, you know, the respect of the patient. I've had some, bless her soul, a first year one time tell me my blood pressure was like 200 over 100. I'm like, really? Okay. I know my range and I don't think it's that high. Without any follow-up either. That, you know, that's really not where you're going. You know, it's a great thing to say, you know what, your blood pressure is 130 over 80. It's a little bit higher than what we would normally like, but of course it depends on getting a trend of how your blood pressures run to see how things are going, because sometimes people get a little nervous with doctors. You know, just a little education thrown in there, that kind of thing. And reality is most of you guys are not going to actually be doing those. Those are going to be the MAs, medical assistants, or the nurse will be doing them. But, you know, practice. Practice, do a full encounter and practice doing vitals. Practice doing the intake. Practice reviewing ice. Practice whatever you would want to do as an assessment, and then practice seeing your findings, you're reevaluating the ice and setting up a plan. Because that ending is so key. If you guys, especially your second years, those of you that are raise your hand if you're second years. Okay. Okay. All right. First years, don't worry about this yet. Okay. Second years is the closing. I remember last year, a lot of people in the beginning of second year struggled with closing. Doing those points to close that I just described to you, I think you're going to be very impressed with how you're going to feel at the end of your encounter. And you're also going to, I would be very surprised, or I would love to hear how you guys do when you're grading, if you follow those steps in the closing. And if you have to write that on the yellow cheat sheet, go for it. You know, write in, review ICE, formulate a mutual plan, close, ask any questions, and then let them know what the next step is. There's nothing wrong with that. And as I told you guys before, I think some of you came in late, take your full time in the encounter. Do not rush out fast. If you think if you're in total mind freeze, just say, you know what, Andrew, can I just sit down for a minute? I just want to review my notes to make sure I'm giving you the best possible care and that there's no other questions. And it could be a very long minute. It could be a couple of minutes. It's your time. There's no one is going to say, you've communicated to the patient, Everyone's scared of silence, but the reality is you need time to recollect your thoughts. You're not a robot. You're a human being providing holistic medicine to people. That means that you need time to regroup to do the best you can. I think most people would rather have that than to have somebody who fakes it, Any other thoughts?
Faking it is I think that's worth it. I mean, we're not here to necessarily talk about the biomedicine as opposed to the interaction, but this is the time that we have designated to learn, to practice. So like when you're feeling a pulse, like actually get it right and feel the pulse. Don't make it up. I've had partners on the ambulance that have completely made up blood pressures, and I know it, and it's dangerous. And it's not acceptable. I would rather hear, you know what, I just can't hear it. I can't hear it over the engine noise in the ambulance.
Oh, God, I can't imagine what you guys go through.
But, I think this is after you leave here and after you leave SPEx and all of these encounters, this was your time to learn and to practice. So if you're having trouble with the blood pressure cuff, take a minute and figure it out. Acknowledge that the Velcro is broken and it's not working or the dial's not working.
Do you guys have to buy your own, don't you? I know we have our own standard. Get your own and get used to it, because practice that one. If you have your own equipment you like, I would try to avoid using the equipment in the room if you have your own that you're more comfortable with. I mean, you all pretty much know what's in the room, So if you like, I've seen people bring their own eye and ear scopes in there, and that's there's nothing wrong with that, because you never know if something's just wacky with the one you have in there, or it's just not something you're not used to. But if you have a comfort level with your own stuff, it's one less thing to be nerve-wracked about when you get into the rooms.
Yeah. And eventually they're going to be checking you. So they'll know if that blood pressure is wrong, or if you weren't actually feeling a pulse, or if you didn't listen to lung sounds in the proper place. So use the opportunity. I mean, Jason's in a unique position where he actually knows.
I do.
If you're doing
it.
So I know a lot of times we just want to follow the rubric and say what we know the rubric says, because that's how we get the check mark.
But yeah, getting the skill, there's definitely a key point of that, of the confidence level versus being cocky. You were about to say something?
Oh, yeah, I was just going to say, maybe you already had this plan, but I think at least for the first two, it would be a good idea for you maybe to do a mock, mock SPEx, at least for the first 5 minutes of what you would do for SPEx.
Sure. Yeah, absolutely. We got time. I'd be happy to pretend to be a doctor.
Yeah, I'd have someone here to be a SP.
Yeah, we could even do it at the end of this encounter if people want, someone who wants to be my patient.
Yeah. You guys like that in the first year? You guys want?
Yeah, that would be
Okay, absolutely. What time do we have till? At least 1 o'clock?
Yeah, book till 1.
Book till 1. So why don't we do a couple more minutes of questions, and then I can go through a spec with you. All right. And anybody else got questions, concerns? Okay, on a scale of 0 to 10, was 10 being the worst anxiety you ever felt in your life? How are you guys feeling at the beginning of this, in terms of worried about how you're going to do this year? Okay. 7, 8, okay, be honest, okay. After this information, what is your anxiety level towards going to the future? Be honest. Do you think, has it helped at all? Do you feel it's giving you better insight? Who feels more confident? Okay, good. Excellent. And why do you feel more confident?
I think just not knowing, never done it before,
Uh-huh.
and actually going through it once and seeing how easy it is to interact with the patient makes you more confident for future interactions with other patients.
Exactly. And that's normal. Like I say, the goal isn't to make it something that you can sleepwalk through. You want to be on your toes. You want to know what you're doing. You want to do a good job. That's a sign of a good doctor. But what you want to avoid being is somebody who goes in there and is either too anxious, and God bless their souls. I've seen people go in there and leave in 5 minutes. And I'm like, oh, you know, it's like, you know, you had so much more there. Take your full time. Andrew, oh, that reminds me. Last year, you guys weren't sure, like, when you guys go line up in the waiting room before you go in, has your professors clarified whether or not they'll let you know what setting you're going to be in? Like, I remember last year you guys had said you didn't know what to expect, like where you were even going to be.
Sometimes it's a small clinic, but most of the time they want us to ascertain that for ourselves and get in there.
Which seems a little unrealistic because you know where you are when you're, you know, the emergency room versus primary care. It doesn't hurt to ask, try to get that information ahead of time. Is like, you know, just to get an idea. Other thing, if you are first years and you haven't been over there yet, I don't know if they allow it, but you should be allowed, I would think, to look through and see what the actual spec rooms look like. Learning how to navigate the table up and down and know where the equipment usually is. Every room will have hand sanitizer and the equipment you need inside of it if it's not, if you didn't know that already. Yep.
Oh, I always forget this in the beginning. It's like really silly, but I always forget to ask them like for their name, their age. Like I always forget to ask about their age. Sometimes it's on like the sheet on the door, but sometimes it's not. And then what's that other thing? Like I ask them like what race or ethnicity do you go by, like just to get in my records.
Yeah, you don't. I wouldn't worry about the race ethnicity for us, but
What about for age?
I would just say use date of birth because then you get their age and it's a patient identifier. So you know, to say, you know, hi, and so you are Mr. Smith, because there'll be like J. Smith on their sheet. You go, J. Smith, oh, okay. Joanna, oh, nice to meet you. Is that what you'd like to be called? Nice to meet you, Joanna. Can I just verify your date of birth, please, for our records, for your patient safety, you know?
So something I like to do, because I always freeze up when I have to do mental math, is I ask them how old they are, so I don't need to do the math, and then I ask them to confirm their date of birth. So they're like, how old are you? Okay, 76, and can you just confirm your date of birth?
And that's good if they're like really, you know, oh yeah, I'm 45, you know, it's like, whoa. So, oh, you hit your head yesterday. Okay, now we're going. But that's an excellent trick, yeah.
I always mess it up, like 70,
Yeah. So, any other thoughts? Okay. Well, I would be happy to do my impression of a DO student. Can I borrow someone's notebook and a pen for a moment? Or something. Does anyone actually write anything anymore? I just need something to be able to, like a clipboard-ish kind of situation. Oh, thank you very much. Great, thank you. Great. So, guys, what I'm going to do here, and again, okay, we got the name. I'm going to tell you guys as I go through. I want to make sure I got it all down before I tell you what it is. Okay, name, date of birth, complaint, onset. Okay, you know. See, I don't even know what the things are. It's like, is it, like you're doing like onset and then problem, pain, or? Help me, yeah, you guys help me out with this one. So it's onset and then you got the whole like P, Q, R, S, T. Okay. Okay. Timing, okay. You're very welcome, good luck. Okay, ICE, family. Okay. Demographics, okay. All right, guys, what I'm gonna do here, I would need somebody to be the patient. Come on, it's therapeutic to actually, it's so much more fun. I'll tell you, as a nurse, it's so much more fun being the patient than it is to be the nurse. So, all right, come on, step right up. Okay. All right, guys, so what I'm doing right now on the little cheat sheet is get the person's name, date of birth, chief complaint. You know, we're gonna find out onset stuff, and then I did the O to T. ICE, family demographics, and just sort of get from there, just to give an idea of what it's going to be to open. And again, I totally emphasize with you guys on how hard this stuff can be. Do you want to take a seat right over there in a chair? And I'm going to grab another one right here. But now it can be fun. So, students, you may begin your clinical encounter. All right. Read it all over. Okay, so this guy is Jay Smith. They don't have a date of birth on here. Let's say vital signs stable. Okay, his complaint is he has knee pain. Okay. So what I'm going to do is go in here and then read it over, see what's going on. This is supposedly, say, it's a 20-minute encounter. And you know you're going to get a warning at 10 minutes. Okay. Okay. Knock, knock, knock. Okay, thank you. Hi, Mr. Smith. Hi. Squirt, squirt, squirt. Hi. My name is student Dr. Jason Pendergast. I'm here with the medical staff here at UNE. It's nice to meet you, sir. Now, how do you like to be called, Mr. Smith? You like to be called Jay. Okay, great. Great. And Jay, can I just verify your date of birth?
February 1st, 1992.
God, I'm old. All right. It would be okay if I sat down for a moment?
Yeah, sure.
Great. And are you comfortable where you are? Yeah. Can we get you anything? Okay, great. Well, as I said, I'm one of the student doctors here, and I'm going to come in here, see what's going on with you today, and then try to figure out what's going on to help you out. Does that sound like a good plan for you?
Yeah, that sounds good.
Great, awesome. So I read up on your door sheet that it says that your chief complaint is knee pain. Could you tell me which knee?
My left knee.
Left knee, okay. And I looked in there and your vital signs were all stable, which is what we like to see. Blood pressure was blah, 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 blah. You might not have to do that, but I'm just giving you guys the gist. Okay, so this left knee pain, how long has this been going on for?
Since last week.
Last week, okay, ouch. And on a scale of 0 to 10, with 10 being the worst pain you possibly had and 0 being no pain, what would you say it is?
Probably like 7.5.
Woo! And has that been constant throughout?
It's like intermittent.
Oh, okay. Well, that must be really painful for you. Yes. Has anything made it better?
When I don't move it, like just lie down and put ice on it, gets better.
Okay. And anything making it worse?
Whenever I move around.
Some movement makes it worse. Okay. And well, that's got to be very painful to be dealing with for a full week. Yeah, that's. How are you handling it?
I just take some Tylenol, just put some rest on it,
Okay.
elevate it a bit. Yeah.
And those things seem to have lowered the pain level down from a 7. So at its lowest, what would you say it is?
Probably like 5 or.
5, okay. And it doesn't get higher than the 7.5, or does it stay around that?
No, it's just around there. It's not
Okay.
too high.
Okay. And does it radiate anywhere?
Sometimes it radiates down my leg to my foot, but very rarely.
Okay. And have you noticed any swelling?
Yeah, there's a bit of swelling.
Okay. And does the pain or the swelling change during the day?
Not really. I mean, only like when I move around just a bit more.
Okay. And do you have any ideas of what this could have happened?
Well, I was playing basketball and I tripped.
Oh.
And I fell on my knee.
Mm-hmm.
So I felt like that might have been the cause.
Mm-hmm. Okay. And any concerns right now aside from the pain?
Not really.
Okay. Just so it'd be fair to say that your expectation today is to get the pain level under control and maybe get back to moving the way you were before. Would that be acceptable for a plan for today?
Pretty much. I just want to make sure I didn't like tear any ligaments or anything like that.
Oh yeah, absolutely. So a concern might also be that you might have torn a ligament. Okay. And okay. Alrighty. And next, I would go into family history. And let me ask about your parents. Are they both alive? Yes. Is there any significant family issues with your father? Does he have any significant health issues I need to know about?
Nothing really related to the knee problem.
Okay. In just heads up, in situations like that, you might want to clarify though that they're like, it turns out your father has osteoarthritis in his arms. That might, you might want to dwell a little bit in, but again, that's something you guys will get more comfortable with in the future. Okay, so Jay, what I would like to do now is just go over what we talked about to make sure I've got a complete picture of what's going on. You're in here was left knee pain. It happened, you said last Monday, is that correct?
Yep.
last Monday. You were playing basketball and you injured it, and you're concerned that you might have had a torn ligament. Okay, it's about a 7.5 out of 10 pain at its worst, and that's usually during movement. When you don't move it and you take your Tylenol and your ice and your rest, it's about a 5 out of 10 pain. Okay, and you've noticed some swelling on there when you move it. Is that correct? Okay, and we've gone out. Your idea is that you think you tore it. Your concern is that you want to make sure that you didn't tear the ligament. And your expectation today is that we try to figure out what the next step is to get you back to where you were beforehand. How does that sound? Okay, great. Awesome. Oh, okay. Great. Okay, awesome. All right, everybody. Any questions on that? Any final questions? All right, I'll be outside for a couple minutes if you do. Thank you all very much. Thank you. Yeah. This is yours? Yeah.